Let's talk about acute interstitial nephritis. Acute interstitial nephritis is essentially an inflammation affecting the interstitium of the kidney. There are many causes. The most common cause is your medications, particularly aspirin, NSAID, antibiotics, and PPIs like omeprazole. So you may be given a case of a patient who had an upper GI bleed, was started on omeprazole, and then 3 weeks after is presenting to you with non-specific symptoms like fever, fatigue, malaise, and then you check the patient blood and you find an eosinophilia. You find that the patient have developed an AKI or an AKI on a CKD, and there is white blood cell cast in the urine, right? And this is a typical presentation of acute interstitial nephritis. It can also be associated with rheumatologic disease like Sjögren, SLE, sarcoidosis, and also infection, right? So medication, which is the most common cause, rheumatologic diseases, and infection, all right? So how does it present? So like I said, right, the patient may have one of these underlying causes, may have been recently started on one of the typical medication I mentioned, and they will basically have an acute kidney injury. They may have a fever, they may have a rash, they may have an eosinophilia. You may also find eosinophil in the urine, but the presentation is not always classic, okay? Um, in terms of diagnosis, the diagnosis is based on a combination of the clinical presentation. You want to do a CBC and look for the eosinophilia. You want to do a UA, a urine analysis, and you're going to find WBC in the urine, RBC in the urine, some protein in the urine, and you may also find WBC Cas and even leukocyte esterase, but there will be no bacteria in the urine. It's a sterile pyuria. So you know that this patient's symptom is not due to a UTI or pyelonephritis, because yes, there's WBC Cas, there's WC, there's leukocyte esterase, there's an AKI, but there's no bacteria in the urine. And that will tell you that this is an acute interstitial nephritis. You can also do a renal biopsy, which is not usually required. It's usually indicated in patients who are not responding to treatment and in whom the diagnosis is not certain. But essentially, what you're going to see is inflammation and edema involving the tubules and the interstitium of the kidney. So, how do you manage this patient? Essentially, the management is to discontinue the offending medication or treat the underlying condition. Treat the rheumatologic disease, treat the infection, stop the medication. Some patient may also need steroid. It's an inflammation, so steroids, systemic steroids can be helpful. And in patients who do not respond to therapy, dialysis is a last resort.